All right, so if we're thinking about the cervical spine, we need to know where we are in the cervical spine to figure out what techniques we need to work on first. Okay, so if we are in the lower cervical spine, typically the progression is to work on AP, then shear, then PA. All right, the reason for that is the person who has the forward head posture, typically the biggest dysfunction out of any dysfunction is that they are going to be potentially relatively sheared forward. Okay, and then we need to work on side bend rotation or shear, and then we need to work on PA last. Most of them are over kind of extended, and we're just cleaning up PA at the end. That's not typically a huge emphasis with mid-lower cervical spine. Okay, whereas with upper cervical spine, we need to work on shear before we work on AP, before we work on PA. Okay, and the reason for that is people will oftentimes, if they have an upper cervical spine dysfunction, oftentimes they can be self-manipulators where they've kind of gone through their life and they'll just like go through and kind of manipulate in a rotational manner their upper cervical. Okay, and so and furthermore, you know, if we have this postural kind of dysfunction, oftentimes if you look at people, there is a shear component to C1. So what Greg Johnson teaches in the Institute of Physical Art is if you work on shear first, then all of the other mobilizations will hold a bit better. Okay, so we're looking at C1, especially C1 shear. So we work on shear or combined side bend with rotation, and then we work on AP, and then we work on PA. Now this isn't always true for every person, right? It's an individualized approach as well. So you could treat the hardest infill. You could also just treat what do you think the most important thing is to get whatever is restricted on axis first before you do the other mobilizations, okay? So there may be an obvious kind of shear to one side that's happening from the mid-cervical, in which case you would want to try to correct that shear first, okay? It may not always be anterior to posterior. Same thing with upper cervical. It may be that there's this big anterior translation for whatever reason. Hopefully not, because we have some strong ligaments in our upper cervical spine. But there may be this big anterior translation that you want to get to sit a little bit more posteriorly before you do shear. But all that said, we want to work mid-lower. We want to do AP, shear, PA. Upper cervical, we want to do shear, AP, PA. That's it.